All right, well, we'll get going, and we'll just have to give Dr. Leavitt a hard time when he gets here. Thank you, everybody, for coming this afternoon. I'm Matt with Snoasis. There's some white cards possibly on your seat. If not, see my team outside. If you fill one out, we're going to be doing a little raffle for some free BioXclude product. But excited you could join us. Looking forward to this next presentation. Got a kind of a unique situation having a panel up here this year. Dr. Matthew Fien, Dr. Brad Ross, Dr. John Kim, Dr. Curry Leavitt when he decides to join us again, and then Dr. Israel Puterman who'll be leading us here. So I'm going to go ahead and kick it over to you, Dr. Puterman.
All right, thank you. Thank you, Matt. Is this, yeah, it is on. Okay, good. Well, thanks everybody for coming, spending the afternoon here with us. I'm going to try to make it a little more interactive, but I might forget also. So just, throw something at me. If I want to get some opinions from you guys. I want to get some opinions, some thoughts from everybody here. So if there's any questions, just feel free to stop, and happy to go through things. So remember this case, because we're going to go through this. And, there is a benefit to screw-retained crowns, but not at the expense of this. Just know that. And we're going to go through later on about how something like that is tackled. But the topic of today is going to be these laminar plates, allograft laminar. Curry?
Your mic was on.
Did you ever see the movie Naked Gun? You know when he goes to the bathroom now, you never see it, and his mic was on? That did happen.
That would be good. Legendary.
So I hope everybody knows the article by Homlai Wang and about the past principles. And the past principles are really the four basic principles to guided bone regeneration, the things that really come into play when we want success with our bone grafts. And obviously, if you don't want success, don't pay attention to them. But it's really about primary closure, angiogenesis, space, and stability. And the main thing that we're going to go through over here is space and stability. So space and stability are the issues that really factor more so into why we want to use this laminar plate. Dr. Leavitt showed before, and we had an awesome question exactly about how the BioXclude membrane, what happened to stability of a graft? How does that come into play? If I was Curry and anything Curry touches turns into bone, so therefore he's able to get results that he does. And for me, I tend to use this guy when I want more stability. And this is a cortical plate of bone that comes hydrated and comes in different sizes. It has a 10 by 10 millimeters, it has a 15 by 20 millimeters, and a 20 by 30 millimeters. And all of them come pre-hydrated, and they're flexible and malleable, and you'll see how I generally use them when I'm trying to rebuild a ridge. But they are resistant to pressure. You can definitely cut them, like they're soft. And you can trim them, trim the corners, and they're very, very easy to use. There's another version of one that you have to pre-hydrate, sit in saline for 20 minutes or so, which doesn't really make much sense when you're with patients. Every minute counts. But the biggest thing that this provides is structural stability. And here you can see a little video of it bending. This is the bigger one. This is the 20 by 30, I believe. But you can see how easy it is. It's about a millimeter and a half of thickness. And it really cuts very easily. So you can trim it, you can shape it to what it is that you actually want to form any defect. You can trim it like a like a trapezoidal to go in a proximal. You can trim it over the just over the facial of the ridge. But when do we want stability? When do we need stability? And we typically want that when we are dealing with much more challenging cases, much bigger cases, bigger defects, like this one over here. So with this situation, this is how we would traditionally deal with this. This case is a few years old, and you know, for a vertical deficiency of about 7-8 millimeters, with a horizontal component over here, I really need a lot of structural stability with this. This is not typically resorbable membranes in my hands, or it wasn't at the time. So we take a titanium reinforced cytoplast, we mix with some autogenous and some allograft bone, and put it into place, and make sure everything is very, very secure so that we contain that graft, we have a lot of stability. And after waiting 9 long months, we open it up and we can see that we have really nice shaped bone. This is dense, hard bone, so we know that we can achieve this. We know that we can achieve this so we can place our implant into the ideal position, prosthetically, and that's okay, that's all great. So why not use that every single time? Well, it's because membrane exposures do happen, and they happen at around a 30% frequency. So you'll find in the literature all sorts of numbers, but can you imagine even 52% of the time you have an exposure? And you know when you have an exposure of one of these cases, you have to see this patient over and over and over again, and they really take over your practice. So if roughly 30% of them are like that, that's brutal. So I do everything I can to avoid doing that and stick to more resorbable. So how do we get resorbable, how do we use resorbable membranes in order to be able to achieve that type of result? Well, let's look at Kathy over here. This was a pretty decently mild to moderate defect, kind of like what Curry showed before of the little bowl-shaped defect. And this one even has a little bridge of bone. Really simple, good place to start using a new material, right? So this is what I did. I used the laminar plate. This was the first case that I used it on, and used the rib roast technique, the periosseous stabilization suturing technique with 6-O-glycolon. So the membrane's resorbable, and the sutures are resorbable after 4 to 6 weeks. So everything in here is resorbable. And put a BioXclude membrane over the top of it. Probably fixed it up nicer after the photo. You have to see the happy face in every picture. And then we wait and leave that case for 6 months, and then we start the planning for the implant. And this is how I do it, just plan the case. You could see the augmentation of the bone, and plan for a screw retained crown. I do a lot of customized healing abutments, so in this case I'm doing that, even though it looks like the crown. Customized healing abutment is really just a crown cut off at the gingiva anyways. And this is what the bone looks like. Now to me, this is bone. There are no particles lying around. I'm not removing half the graft in order to get to good solid bone. This is good solid bone on its own because even the membrane is bone. The bone is bone, the graft is bone, and the membrane is bone. So this is rock solid here. Do a little tiny baby connective tissue graft just to thicken up the tissue, and you can see the customized healing abutments. Obviously, the implant placed with a surgical guide up there. Okay, so what about, these types of defects that everybody has? And this is one that our buddy Phil Walton said, wow, if it can work in this situation, he is sold. And he's not here right now, but we'd pick on him otherwise. So if we look at this, you can see that ridge deficiency. There's enough bone to place the implant into, but you have buccal exposed threads. So what do you do here? There are so many different things you can do. Number one, you could do it as a 2-stage procedure, graft first, place the implant later once it heals. Or you guys, John, what would you normally do in this situation? Do you raise a flap, do GBR, do you tunnel something in there?
I typically don't tunnel as much as you do, but I usually will raise a flap. Go ahead and decorticate around it and do the typical GBR I do.
Cool. With what type of membrane would you use there?
BioXclude, of course.
There you go. I knew that. So in this case, I use a laminar plate with no flap. This is just an envelope flap. So no vertical incision, just raise it all the way down to good solid bone towards the apex, and place the laminar plate and do allograft grafting in between the implant and the plate. Implant's in the ideal position, not leaning to one way or the other, which you typically would, and then I put a BioXclude membrane over the top of it, of course, because I want nice healing. And at 13 days, you get nice healing. So now it's a much more beefed up ridge, you can see that. Okay, but what about the bone? Go back in at 4 months to do the Uncovery, because this was a 2-step implant, but there's a problem. What's the problem? Bingo. Can't find the implant. So like with Matt's case before, you need a stud finder to be able to find the implant. So, question, yeah.
Does that laminar bone ever act like a sequestrum rather than a membrane?
Does it ever act like a sequestrum? The only time I've seen that is when a site opened up, which does happen. But I've not seen that happen when the site is healed up properly. So yeah, can't find the implant over here. Good problem to have. So I got to go digging for it, and there we are. Find it, place a healing abutment, and get restored. And these are nice, good, healthy contours where you're not going to have food get stuck underneath because you have a big sort of tomato on a stick with an undercut. Okay, well, how about a little bit of a bigger defect? How does it handle that? So this is how I would do it before using laminar plate. So you can see that there is a buccal deficiency, there's a lingual deficiency. Thankfully, they're good interproximal peaks of bone, so I have someone to work with, but there's a big buccal through and through defect there. So I'm going to use a tenting screw because I really want some good stability for this. I need some support for the graft in that vertical position. So using the tenting screw, graft over it, and using a membrane that's long-lasting with the ribro suturing again. And we wait 9 months in this case, and now, yes, it is possible to regenerate the entire bone all the way up. And that was a good 10 millimeter defect, and we're able to have a 10 millimeter vertical defect. And we're able to have a nice cantilever bridge. And that's all good, but sometimes we don't want the screw. It is easier to not have to put a screw in there as a sort of tenting. So can we do that with the laminar? Okay, well, let's look at Barbara, who has a very similar defect, but it's on the maxillary arch. And she had, you can appreciate the through and through defects, no palatal bone, no buccal bone, and she had an implant, obviously, that failed, and so here we are. You know what that patient did? She was actually scheduled to come in for me to take out the implant and do the graft. She walks into surgery, and she asked me to close my eyes and put up my hand. She has a surprise for me. It was not my implant, I want to say that. And what did she do? She put her implant into my bare hand. And I was like, what are you doing? So I still did the surgery. Wanted to get rid of her. But here's the laminar bone that's folded over the occlusal surface. So I have a lot of stability of that graft. I have that space maintenance. Nothing is collapsing inside of that defect. And then put a BioXclude over the top of it to really shore up any little areas where some graft might come out. Close it all up, 7 months, and complete regeneration of the deficiency. Now there's plenty of bone to place the implant into and be able to restore it with a nice looking crown. Okay, so what about an even bigger defect than that? Well, Dawn is going to be toothless in the lower anterior, So take out those teeth and you can see the ridge deficiency that he's got. And this is obviously not a case where I would do immediate implants, maybe on that 26 site, but certainly not on 23. So there's no use just putting one implant now. So we're going to regenerate. How do we do that? We have a lot of different options, and you can certainly use different materials. You can certainly use, there's a whole host of membranes that'll work over here, but none of them have a happy face like that. So I put my laminar, the laminar plate in here. How does this work again? Put the laminar plate over here. You can see the sutures that are already into the buccal periosteum, because sometimes when you're doing the rib roast, it's really tough to have your laminar plate or have your membrane there and then go past it and work through the graft to be able to get the sutures through. So sometimes I'll place, raise the flap and separate the tissue, separate the periosteum, release it, and then put the sutures, then start putting the graft. And it just makes things a little bit easier sometimes. So you can see that's what I did over here. I have the sutures ready to go, and you guys have a preference when there's one big happy face or many small ones? Many small ones, really? I always prefer the one big happy face. Many small ones? Okay. So wrap it up, kind of like saran wrap, so everything is nice and tight. You can see the BioXclude is tucked underneath the sutures. So this whole complex can't be more stable. You have good buccal contours. You have that buccal shelf that you really want, because once you place your implants, you want to have that buccal shelf of 2 millimeters or so to make sure that the bone doesn't shrink over time. And here we are after 6 months or so. You remember that defect that there was over here? This was a huge deficiency, and now no more. Able to place the implants using a surgical guide, plenty of bone for that, and good regeneration. Okay, well, we keep getting bigger, so how about even bigger? Let's look at this one. I don't know if anybody was here yesterday at ISPPS, but I showed this case there. So this is a case with obviously a really large ridge deficiency in the horizontal plane and the vertical. And so this was really adding a lot of bone. And this is really challenging to do with other types of membranes, because the membrane doesn't really stay in place so well. This really folded it over. So this was done a little bit differently than the last couple of cases, but it's folded over the occlusal aspect, kind of like that one in the upper right, that failed implant, and put the BioXclude over, again, really just to fill any voids that the graft particles can escape from. Question? Yeah.
Was this all allograft bone? No autogenous?
That's allograft mixed with autogenous scrapings. So get primary closure, which is really critical to always critical to success. And on that, yeah, it was not easy to get primary closure. But you do what you got to do, release the tissue as much as you can, and then look at the ridge that we have later on. And if you remember what it looked like before, this is what it looked like before, and then this is what it looked like after. So obviously now able to place as many implants as we want. In this situation, I had 2 Pontics, I think it was like 7 and 8 or 8 and 9, and be able to place our implants with a lot of good buccal bone. Is that a question up front?
Yeah, I had a question.
Yeah.
To get closure, you had to score the periosteum.
Yeah.
Well, how do you get the suture into the periosteum?
Yeah.
Keep scoring it.
Not easily. You really have to, so with the rib roast, you have to have complete separation of that apical portion of the periosteum from the flap. And you test that out as soon as you release that tissue. As soon as you release it and you make sure that it's tension-free flapping, you want to see that apical periosteum just stay in place. And that's well before placing graft. That's something that you have to work on during that procedure. Because you're exactly right, if you do it afterwards, the whole thing's going to be moving. So in this situation, you can see where she started and where she ended up. And yeah, there's pink over here, but in reality, these were really long teeth. Teeth were way longer than these. And so that's okay. What's the problem with having pink like this? What's the problem? Is there a problem? There you go. Hygiene, exactly. So you want to make sure that you can floss in between those implants, and you want to make sure that it's a convex intaglio surface. It has to be. It's the only way things like this can keep clean. And of course, we knew that this was going to be the case. We knew that it wouldn't be a problem because she's got a very low smile line. Okay, so that was, looking at things from the more maximally invasive way of doing things, but what does it do in more minimally invasive techniques where if I'm looking at this case over here and I'm going to be losing this tooth, it doesn't look too bad, but you'll see why. This is Paul. So look at the sagittal slice and the 3D animation of the CT scan, and you can see how there's no bone here towards the apex. There's a lot of resorption of the root. He's had endo surgery, and there is just next to no bone. So normally, I would open a big flap, rib roast, do all that stuff. But this is a guy who does a lot of traveling, and I didn't want to do that. I wanted to keep things really nice and tidy and as minimally invasive as possible. So I'll tell you, this is where we started. This is where we ended. So how did we get there? How did we go from there to there without raising a flap and that type of bone defect? And it's all about preservation instead of reconstruction. As soon as you raise that flap, you've heard it throughout the day today, I'm sure, that as soon as you elevate a flap, you're going to lose some bone, you're going to lose some tissue, you're going to lose some marginal papillae. It's all true. And so if you try to preserve as much as possible rather than have to reconstruct, you're always going to be in a better spot. So how did we do it? Well, this is it. Took out the tooth, obviously, using just forceps and fractured tooth. So remove each piece at a time. And this is the view I have. I use a 3D microscope for all my surgeries, so this is the view that I have. Matt, did you ever get yours in? Use
3 of them.
No, you didn't. You cheeky guy. So look, you can see how, look at the well, I don't know if you saw, but there's no buccal plate there at all. And Matt, so you are in, or you did or didn't? I don't know.
Everyone talks.
We'll talk. So there you can see there's really a total lack of buccal plate. So I made a little remote vista incision. And why did I do that? Really because I found it hard to just work from within the socket. And look, I'm placing that big laminar plate, which it can't fit through the socket unless I raise those papilla. So I kept the papilla intact, and working remotely from that vista incision, I was able to place it, degranulate everything, and then add my allograft. And this is pure 100% allograft. In an extraction socket, I don't bother using autogenous unless I'm really augmenting a whole lot. And I place a PRF membrane, and then, of course, like a little happy face on grafts. And then suture it. Here we are. The only incisions that were made are, intracellular and then around at that vista incision, which you can often incorporate into the frenum.
How did you secure the laminar?
How did I what?
How did you secure the laminar?
I didn't. That's the thing. Just secured because there's no flap elevation, so it's secured just by the tissue, by the periosteum. So after 6 months, this is where we started, and here you can see where we ended up. What's that? It's a lot of bone. It's good. We want a lot of bone. So without raising a flap, just keeping things nice and minimal, and here you can see, appreciate the soft tissue healing with the BioXclude over the top of it. And again, like before, customized healing abutment. I do these pretty much on every anterior case, I think, with a surgical guide, and place the implant. And really, again, no incisions, no elevation of flaps. Okay, I lied. a little elevation of a buccal flap, but that was for just placement of a little connective tissue graft. So I'll do a lot of these where this is not a full connective tissue graft, like, you know, from the side of the palate. This most often is from literally inside the flap, within the flap of the contour of the socket, just on the palatal aspect. You don't need a large graft for a lot of these cases. You just need something to thicken up the tissue. And so all that was I just tucked it under a little bit to be able to place that connective tissue graft. And that's the customized healing abutment designed to keep the contours in place so that I don't have any collapse, and able to develop things from a restorative perspective from day one. And then after some healing, you can see how the tissue really just forms around it. And there's the implant in good solid bone. So here's how he looked in the end. From the facial and occlusal standpoints, good thick tissue, good implant positioning, and now we're at Matt's case that he sent to me, tried to get me to help him. He didn't know what to do here. He said, don't place the implants like that. So it happens. So this is a patient who, obviously her restorative doctor placed the implants and tried to get them screw retained, although I don't know why this one needed that and that one, they could be so divergent. I don't know. No idea, but this is how she presented. And she says, you know, she has this dark tumor coming out of the implant, and that's not a dark tumor coming out of the implant, that's the implant. Right up over here. So she didn't like the vertical discrepancy of the two central incisors. She didn't like anything of it, and she was a really unhappy woman for obvious reasons, and rightfully so. So this is how she looked. These people never have a low smile line, right? They're always going to have a high smile line by definition. So I'm like, okay, well, this is a tough case, and I refer her to a prosthodontist that I work with just down the hallway, and he's like, oh, great, thanks for this case, but hey, this is somewhere where you can actually make a difference. Yes, it's a lot of work, but we can really make a big difference with her. So, see the two implants, you know, is there a problem with having two implants here? Who would, in a situation like this, never mind positioning, who would consider two implants in this case? Who would, of you guys? Who would you consider? Would you ever consider two implants side by side like this with a high smile?
Prefer not to.
I don't.
No?
Cantilever.
And I assume everybody else has one implant? Okay. So, take out the two implants, and using the minimally invasive reverse torque tools that we've got these days, you can still see the threads of the implant in this one. And again, same as before, sticky bone mixed with autogenous, a lot of bone, always over graft. We know we're going to get some dieback. Use a laminar plate that's trimmed and cover the facial aspect. And when there's a big defect like this, then I tend to not use BioXclude. I'll tend to use a more long-lasting resorbable membrane. And so really just the purpose of it is just to contain the occlusal graft material. And this is another tough one, but get a lot of good closure. After some months of healing, this is where we are. Anybody happy here? No? Yeah, probably me neither. I know that I need more, and it's okay. We can get more, but that first step was a big step to get in there. So plan my case, and what I did is I planned for two implants. So there really is nothing wrong with having two implants side by side as long as the case is managed properly and there's enough space and you're working with a good restorative doctor. Having one implant there, the decision was that, with her types of complications that she's had, And we talked to her about, hey, what's most important to you? Whenever there's a issue, like two roads you can go down, bring the patient involved into that decision. Say, what's most important to you? The papilla that is definitely not there now, or is it having a lot of good long-term stability? So you really most likely are not going to have to do this again. And she's like, I don't care about damn papilla. I don't have it. I'm not going to have it. You tell me I'm not going to have it anyways. So yeah, let's get 2 implants in again. Okay. So we measure the spacing, of course, and we know that we could get 2 implants now, yes, into screw-retained positions, but tweak things a little bit. And I meet with my lab regularly and be able to have good solid bone to be able to place the implants. Again, using a surgical guide, especially when you're placing 2 implants side by side like this. You need a surgical guide because the tendency we have is to stay away from those adjacent teeth and we'll kind of slump towards the middle that's the human error side of things. So take the measurement, and how much room do I have? Yeah, 6 millimeters between implants. Is that enough? I think that's enough. I still want plumping because like we saw with the soft tissue, we want more soft tissue. I needed more soft tissue gain. So the way that I got soft tissue gain over here is using a product, a long-term volume stable collagen matrix over the facial aspect, put some over the occlusal aspect, but then as I was kind of tidying things up and seeing how it closed, I said, you know what, I need more. So then did a VIP connective tissue graft to be able to get more volume interproximally to try as much as I can to get that papilla. Close it all up, and hey, for right here, right now, I'm pretty happy with things as they look from the vertical position. And this is how it heals. So definite improvement, big improvement compared to right before the surgery. And then start to shape, once that heals, start to shape the tissue using provisional restorations, and these are the 2 screw-retained provisional restorations that the prosthodontist made. And now this is where the patient is, where we're trying to just shape the tissue, trying to be able to recontour things, make sure she's happy. No, we're not going to get papilla here, but like we said, we didn't have papilla beforehand. It's not a problem. But this is where we started, and this is where we are now, and we actually have bone around the implants as a bonus. Yeah.
How do you temporize the patient during the healing phase?
They always start with an Essex, and the patients who want to eat with a temporary get a flipper. But the flipper will be after initial healing. Like we'll take a scan 2 to 4 weeks after the surgery.
How many years post-op is that?
So she's in provisionals now.
Okay.
So this is less than a year post-op.
I've seen the papilla come back over time.
Sure, and that's why we're leaving her in provisionals.
Couple years, but it does sometimes come back.
It can, as long as there's bone underneath and there's space, the papilla is going to slump in. You got to put a little pressure on the papilla to squeeze it down, and it can come down a little more than this. Yeah.
How long does the lamella bone maintain its integrity?
So I believe was it 12 to 18 months, I recall? So a long, long, long time. Definitely long enough for everything underneath to grow. So the BioXclude and Maxillary laminar plate, they're a tandem. They play well together. Brad Ross, which is your favorite tandem from these guys?
I'm a big peanut butter and jelly guy.
Peanut butter and jelly, yeah? Matt?
Bert and Ernie, maybe?
Yeah? All right. John, Curry?
Kobe and Shaq.
Kobe and Shaq?
I like the Kobe and Shaq.
Oh, it's there. Nice.
Kobe and Shaq? Yeah, of course they're there.
I didn't see it.
Yeah. Well, thank you, everybody. This is just a demonstration of how these 2 materials come hand in hand. Very different handling properties, but they're not exclusively one versus the other. They do help each other, and you can use them in tandem, and just use your materials, know your materials, use them, and that's it.